Hello everyone, welcome to this webinar which is delivered in association with Protective Veterinary. My name is Nick Bexfield. I'm a small animal internal medic at the University of Cambridge in the UK, and we're going to be talking about the use of cobalamin supplementation in chronic gastrointestinal diseases in dogs. So this is a summary of the presentation. We'll start by describing what cobalamin is and why it's required, and then move on to discuss the causes of cobalamin deficiency and the effects of low cobalamin, and then finish by talking about how cobalamin can be supplemented. And as we go through, I'll include one case example for you, a dog called Bella. So I want you to reflect for a moment on which of the conditions that you would routinely test cobalamin levels in. Do you test animals with gastrointestinal disease, dogs with exocrine pancreatic insufficiency? Maybe it's dogs with hepatic disease or renal disease, or possibly there's other diseases. Also want you to reflect on how you currently supplement cobalamin in your canine patients. Is it orally? Or maybe it's via parenteral or injectably? Or maybe you don't currently supplement cobalamin at all. So what is cobalamin? Well, I'm sure you're aware it's also known as vitamin B12. It's a water-soluble, cobalt-containing vitamin, and it's synthesized by bacteria in the large intestine of dogs. But the site of synthesis is caudal to the site of absorption. As we'll see in a moment, the site of absorption is in the ileum, and that means that cobalamin is a required dietary nutrient, and things like meat, liver, eggs, milk have got significant amounts of cobalamin in them. Of course, commercial dog foods may well be supplemented as well in cobalamin to make sure that animals have adequate dietary intake. And in the diet, cobalamin is bound to protein. It's a very large molecule that can't cross the intestinal epithelial barrier, so it needs help from a particular binding protein called intrinsic factor. And intrinsic factor is predominantly secreted from the pancreas in dogs, smaller amounts from the stomach. In cats, it's only secreted by the pancreas. And so this intrinsic factor cobalamin complex binds to specific receptors on the surface of ileal epithelial cells. And then on binding, the cell-mediated endocytosis to internalize this intrinsic factor cobalamin complex, and then cobalamin is transported into the bloodstream. And the schematic on the right-hand side of this slide is taken from Protective Veterinary literature. And I'll just briefly run through the metabolism and uptake of cobalamin. So at number one, cobalamin, which is bound to protein, is ingested. Also at number one there, you can see a green triangle, which is salivary R protein. This is a glycoprotein secreted by the salivary glands, and it binds to cobalamin and it protects it from the acid in the stomach. So we have cobalamin that's ingested, R protein produced. At number two, gastric pepsin breaks this cobalamin protein bond, and so the protein is digested and cobalamin is released. And it very quickly, as I say, binds to this R protein at number three to protect it from the acid environment of the stomach. And then number four, this R protein cobalamin complex is broken down in the proximal small intestine by proteases. And then number five, cobalamin binds to intrinsic factor, which in the dog is secreted predominantly by the pancreas. And then at number 6 in the ileum, cobalamin is uptaken by this cobalamin intrinsic factor, which binds to receptors. And at number 7 there are alternative mechanisms which are independent of intrinsic factor, and it's thought that when there's very high intraluminal levels of cobalamin can be absorbed by separate pathways, so that's depicted in number 7. And so these separate pathways, it's thought that when there's a large amount of cobalamin present, at least in the human small intestine, cobalamin can be absorbed by passive diffusion across the whole length of the small intestine. It's not known if dogs and cats can absorb cobalamin by this mechanism, but it's thought that it's probably the case. So of course in animals with gastrointestinal disease, if that disease affects the ileum, you can see why there may well be problems with cobalamin absorption. So cobalamin is important for many physiological processes, and these are listed on here. So cellular metabolism, DNA synthesis, amino acid metabolism, fatty acid metabolism, new red blood cell production, to name but a few. And it's also an important coenzyme, meaning that its presence is required for many enzyme catalyzed reactions. So it's a pretty important substance. So what causes cobalamin deficiency? Well, the most frequently identified cause is chronic enteropathy, and chronic enteropathy is a sort of encompass all term, and so any chronic gut disease is known as chronic enteropathy, so that can include things like inflammatory bowel disease, neoplastic disease, and many others. So we definitely know that dogs with chronic enteropathy are very frequently have deficiency in serum cobalamin. We also know that dogs with exocrine pancreatic insufficiency, or EPI, also develop cobalamin deficiency and develop it relatively commonly. And one of the main reasons for that is because they are not producing sufficient intrinsic factor. And we know that certain breeds develop a familial cobalamin deficiency. So familial disease is a hereditary one. Often these animals present in relatively early in life, in the first year to 2 to 3 years. And there's lists of breeds on the slide there, and there's other breeds as well. We definitely see occasional border collies with a familial cobalamin deficiency. So yeah, it's very commonly associated with canine chronic enteropathies, and depending on the individual study, anything from 6 up to 73%. And again, the deficiency in cobalamin in these dogs with chronic enteropathy is likely due to damage to the ileal epithelial cells, so there's not the uptake of this cobalamin intrinsic factor complex. And we know it's a negative prognostic factor in dogs with chronic enteropathy and EPI, so cobalamin deficiency is, and it's associated with an increased risk of euthanasia. So what causes cobalamin deficiency? So yeah, it was mentioned in exocrine pancreatic insufficiency. It's definitely results from a reduction in production of intrinsic factor, but there are also other mechanisms as well. So whatever the cause of reduced cobalamin absorption, depletion of cobalamin stores occurs, and then the deficiency ensues. So what are the effects of low cobalamin? So the effects have a number of profound metabolic and clinical consequences, some of which are listed on here. So they include anorexia, weight loss, failure to thrive, central and peripheral neuropathies, immunodeficiency, And importantly, intestinal changes. So sufficient cobalamin is required for villi growth and formation. So you get villus atrophy and then malabsorption of other vitamins and nutrients. So it's really important to remember that dogs and cats with gastrointestinal disease and cobalamin deficiency may not appropriately respond to treatment of their underlying disease unless you supplement cobalamin. So you may have made the diagnosis, you're treating the underlying disease appropriately, but unless you address the deficiency in cobalamin, their clinical signs will only partially resolve, or in some cases, poorly resolve. So let's have a look at a case example. Let's have a look at Bella. So let's have a look at Bella. Bella is a 4-year-old female neutered crossbreed. She has a 6-week history of progressive diarrhea. There was no increase in frequency. There was more feces passed at each event. There was no dysgeusia. There was no blood or mucus. She occasionally vomited, and there was definite weight loss, and she had a reduced appetite. So we always try and categorize diarrhea into small intestinal or large intestinal diarrhea. And if you have a look at Bella's diarrhea, there was no increase in frequency, there was no straining, there was no blood, there was no mucus, so all those things you would expect in large intestinal diarrhea. But with significant weight loss, that definitely suggests that she's got small intestinal diarrhea. And the referring vet had tried to manage her on a single protein diet for an adequate amount of time, for about 6 weeks, and there had been little improvement in her clinical signs. So on clinical examination, Bella had a reduced body condition score. Abdominal palpation was quite difficult just because she was quite a tense dog. Temperature was normal, but there were soft feces on the thermometer. So when we face with a case like Bella, we often think about using the problem-orientated approach. I'm sure you've come across this. This is when you think about the problems an animal has, and then you try and prioritize those problems or place them into primary or secondary problems, and then you think about differential diagnoses for those problems. And so if you use Bella, you would probably conclude that problems include this 6-week history of diarrhea, the occasional vomiting, weight loss, reduced appetite as well. And you might split those into primary and secondary problems, in that you might think primary problem is the diarrhea and the secondary problem is the weight loss and probably the reduced appetite as well, and occasional vomiting could well also be a primary problem. And then we think about differential diagnoses, and this is a moderately complete list of differential diagnoses for chronic small intestinal diarrhea. We do this so then we move on to do tests to try and identify the cause of an animal's clinical signs by ruling in, ruling out conditions. So you can see that there's a number of small intestinal diseases on there. Inflammatory bowel disease, very common. SIBO, or small intestinal bacterial overgrowth, probably less commonly identified nowadays and maybe less clinically significant. Definitely neoplasia, partial obstruction, and other small intestinal diseases. Liver disease secondary to portal hypertension leads to diarrhea. We see diarrhea with renal disease, hypoadrenocortism, and drugs and toxins. So good history is really vital. Dietary is another important group. Yeah, we sometimes see dogs that do chronically scavenge, but we definitely see animals with chronic diarrhea that have got a dietary allergy. And then infectious causes on there. Exocrine pancreatic insufficiency and chronic pancreatitis, two final causes of chronic small intestinal diarrhea. So something that I'm sure you'll often do is to, in a case like this with gastrointestinal signs, is maybe try and split the differential diagnoses into those that occur outside the gastrointestinal tract and those that are of the gastrointestinal tract. And so we did some clinical pathology to try and rule out extraintestinal causes, so particularly things like renal disease, liver disease, hypoadrenocortisone, to name three more common extraintestinal causes of diarrhea. So let's have a look at the results. So you can see the abnormal values highlighted in red. There's a mild increase in glucose. There's a reduction in albumin and globulin, relatively significant reduction in both of those, particularly albumin. There's an increase in hepatocellular marker, ALT, marker of bile stasis, ALP, and there is a slight increase in phosphate, which you may well conclude, as we did, is clinically insignificant. Remember, you don't have to explain every single abnormality on clinical pathology. Sometimes it can just be normal variation for that animal, why a value is just outside the reference interval. So what are your thoughts on the results of serum biochemistry? Do you think Bella has got liver disease as a cause of a chronic diarrhea? Do you think she has diabetes mellitus? Or are you worried that the combination of low albumin and globulin suggests a protein losing enteropathy? Or maybe you don't do clinical pathology and you're relying on the clinical pathologist to interpret these results for you. Hopefully the latter is not true. So just to briefly run through those. Yes, she could have liver disease as a cause of her diarrhea. She does have an increase in liver enzymes, but I'm sure you will see many dogs with mild, moderate, marked increases in liver enzymes. And of course, as you well know, not all of those animals has got a primary liver disease. There's in fact more animals that have got what we call a secondary or reactive liver disease. So there's something going on outside the liver which is upsetting the liver and leading to an increase in liver enzymes. So good examples are things like endocrine diseases such as Cushing's disease and diabetes mellitus. But you'll also see increased liver enzymes in animals with gut disease because of bacterial antigens and inflammatory cytokines and things passing to the liver via the portal vein. You'll see increase in liver enzymes in things like pancreatitis and bad dental disease and bad skin infections, otitis, etc., etc. So, as you well know, finding an increase in liver enzymes doesn't necessarily mean the dog has primary liver disease. Could Bella have diabetes mellitus? Well, no, I would say to that, because A, the glucose is nowhere near the renal threshold, it's only slightly increased, so there'll be no glucoseuria, which is the hallmark of diabetes mellitus. And very importantly, and this is where it goes back to a good differential list, you won't have seen diabetes mellitus on the list of causes of chronic diarrhea. What about C? Combination of low albumin and globulin suggests a PLE. Yep, that's true. We know that there's several causes of low albumin that we'll come on to in the next slide. That combination of low albumin and globulin, especially with a history of gastrointestinal signs, definitely supports a protein-losing enteropathy. So yeah, several causes of low albumin, liver disease, protein-losing enteropathy or protein-losing nephropathy. And if you have a low globulin as well, that normally suggests protein-losing enteropathy, particularly in the context of chronic gastrointestinal signs. And there's not actually that many causes of protein-losing enteropathy. The major causes include things like inflammatory bowel disease, particularly the moderate to marked lymphocytic plasmacytic, but also things like the eosinophilic or maybe the histiocytic, lymphangiectasia, and also neoplasia, particularly diffuse neoplasia, which is primarily lymphoma. So how would you investigate Bella further? Well, you've done serum biochemistry, and we will have done hematology, the results of which were within normal limits, to try and look for extraintestinal causes of diarrhea. So you'll probably move on to do some sort of imaging to look for many of those other causes on that differential diagnoses list. You're probably not going to jump in straight and do gut biopsies. You're going to do the least invasive tests first. So let's have a look at some imaging. So this is results of ultrasonography, and we would tend to do ultrasonography rather than radiography because usually get a lot more information. And in Bella's case, there was an increase to the intestinal wall thickness, but there was no loss of layering, which is good to see, and a small amount of free abdominal fluid. And so there's reference ranges there depending on the size of the animal, and so Bella was around about 20 kilos, so significantly increase in thickness of the small intestine. Looking for loss of layering is good, so you should normally be able to see those different layers on abdominal ultrasound. If you don't see those layers, it'd be very supportive of neoplasia, but you can sometimes see loss of layering in inflammatory disease as well. So how else could we investigate? Well, we really need to try and take samples of the intestines, and there'll be different ways to do that. Fine needle aspiration, although relatively very non-invasive, is not a good way, of course, to try and sample intestines. So we're thinking about endoscopy or exploratory surgery. I would be cautious about performing exploratory surgery in Bella because her albumin is significantly low. There may be risks of wound dehiscence. Many of the drugs we use for general anesthesia are protein bound. There's fluid present in her abdomen as well, which you'd have to remove. So we took a non-invasive approach, and we did that because it looked like she'd got diffuse disease throughout her intestines, and also the mucosal layer probably was affected. Whereas if you had an animal that had got disease in the distal small intestine that you couldn't reach with the endoscope, or you'd got disease that was not in the mucosal layers, so the deeper layers, and those would be two reasons not to go for endoscopy. So there were actually no mucosal abnormalities present, but we took biopsies from her. We took several from the small intestine, but also from the stomach as well. And the results of histopathology, there was a marked infiltration by plasma cells and lymphocytes, and so the diagnosis was inflammatory bowel disease of unknown etiology. And that's often what will come back, IBD of unknown etiology.
So IBD, its a definition is here, it's a collective term for a group of chronic gut diseases characterized by persistent or recurrent gastrointestinal signs and inflammation of the gut. So IBD is characterized by intestinal inflammation. The problem always is ruling out the underlying cause. And we know that IBD in dogs and cats, like it is in humans, is sort of interplay between the host's immune system, so genetics comes into it, hence why certain dog breeds are predisposed. Definitely interaction with the gut flora, what we call microbiome, and then lots of environmental factors, things like diet, but others. So the cause is multifactorial. And one way that we sometimes retrospectively classify IBD is depending on the response to treatment. So remember, we're just saying this is an animal that's got chronic gastrointestinal signs and we found inflammation in the guts. The problem is, what's the cause of the inflammation? Could it be a food allergy? Could these animals be responding to a type of bacteria that's in their intestine, maybe an abnormal bacteria, but actually maybe more likely just an overgrowth of one type of bacteria or an imbalance of their microflora? Or are these patients with IBD those that don't fall into these categories and actually have idiopathic disease and require immunosuppressive drugs? There's no way based on a biopsy to determine this, hence why it's a retrospective diagnosis. So the management of an animal with inflammatory bowel disease, and it is a very common presentation in at least our referral practice, and I suspect, therefore, it's a very common presentation in dogs with chronic gastrointestinal disease in practice. Ultimately, it can only be diagnosed by taking biopsies of the gut. So it's important to rule out all those other causes before you do something that's relatively invasive. And the management is, for me, often influenced by the severity of the disease. So that might be an animal with very marked clinical signs, or an animal with low serum albumin, or possibly if there's very severe or marked inflammation on the biopsy. And often those three things go together, i.e. if there's very severe inflammation, or particularly if it's something like an eosinophilic IBD, those animals are more likely to have marked clinical signs and a low albumin. So animals with very mild to moderate disease and a normal serum albumin, so relatively mild signs, aren't systemically unwell, aren't dehydrated, etc., etc., you might be able to use a sort of sequential approach to treatment. So you make sure they've had good endoparasite treatment. If in doubt, retreat them. Think about treating them for Giardia as well, importantly. It's quite difficult to diagnose. Then maybe you're going to think about a dietary trial. For me, I often try and do 1 or 2 dietary trials. Minimum of 4 weeks. Most dogs will respond within 4 weeks. Occasionally they take a little bit longer, so sometimes we'll continue for 6 weeks. I either use a novel protein diet or a hydrolyzed diet, and there's lots of these types of diets on the market. And of course, it's important the animal is just fed that diet. Some people advocate the use of antibiotics to try and modify the bacterial flora, so using metronidazole or oxytetracycline. They're used less commonly nowadays. I must say we uncommonly reach for antibiotics in these animals with chronic diarrhea, particularly if we diagnose them with intestinal inflammation. So if the endoparasite treatment isn't effective, the dietary trial or trials aren't effective, or the antibiotic trials are not effective, we say these patients have probably got idiopathic disease. We need to use corticosteroids.
But in the patient with severe disease, especially those that have got protein-losing enteropathy, so just like Bella, the dog that we've been discussing, you probably don't have time for that staged approach, because it takes time to go through each of those stages, and with time there's a risk that the serum albumin is going to decrease further, and the animal is going to get severe complications, i.e. effusions and pulmonary edema, etc. So we often go for concurrent therapy. If there's been no endoparasites used, we'll maybe use endoparasites, and then use diet, possibly with antibiotics, although, as I say, we tend to use those far less commonly nowadays. So it's predominantly diet and corticosteroids given from the start. And then we might need to add in an additional immune suppressive drug if the response is suboptimal or the side effects of corticosteroids are severe.
So this is the sort of, we tend to use prednisolone, and the starting dose is usually 2 milligrams per kilogram per day. That's a standard immunosuppressive dose. Shouldn't need to go any higher than that. And then there's lots of suggested protocols for how to reduce the dose down. This is one, but it's when you're treating any inflammatory or immune-mediated disease such as this, it's always a balance between side effects and clinical signs. So if the animal's having severe side effects of steroids, you may well reduce the dose more quickly or add in another drug. Whereas actually, if the disease is not that well controlled, you're probably going to continue with a higher dose for a little bit longer. But this is sort of a rough idea. We're dropping the dose sometimes by 30%, sometimes by 50%, usually every sort of 3 weeks roughly. But as I say, don't take this for gospel. There are lots of different protocols, and it's a balance between signs, clinical signs, or how well you're controlling them, and side effects. And if the response to steroids is poor or the side effects are severe, you might need to consider other immunosuppressive drugs in these dogs with idiopathic inflammatory bowel disease. And there's different options on there, and studies have looked at the addition of chlorambucil in dogs with PLE and found that's effective. And a more recent study has looked at cyclosporin, which is probably my go-to drug in dogs with steroid refractory IBD. There's other drugs we sometimes use as well. Another one you may have come across, mycophenolate, which again there's a bit of data on in animals with inflammatory bowel disease. So do a literature search if you're interested in using that drug.
Okay, so that was a brief overview of IBD. What did we do in Bella? Well, we used prednisolone, 2 milligrams per kilogram once a day. That's our, as I mentioned before, our go-to first-line drug, and a good quality diet. And it wouldn't have been wrong in Bella to maybe trial another novel protein or a hydrolyzed diet. And then follow up at 3 weeks. There was a slight reduction in frequency and severity of the diarrhea, increased appetite, which was good, but there'd been further weight loss and the owners were still unhappy. So we started an adjunctive immunosuppressive drug by way of cyclosporin. So what happened? Well, we followed up after another 7 days, and in fact the diarrhea had worsened, and I think she'd even lost a little bit more weight, and the owners were really unhappy now. So what have we missed? Well, of course you'll realise what we've not measured in her case. And so we measured serum cobalamin and folate as well at the same time. The cobalamin was significantly below the reference interval. The folate was within normal limits. And so we administered oral cobalamin by way of Cobalaplex for started that, and she had a 6-week course. So really importantly, don't forget to measure serum cobalamin and folate in cases of chronic gastrointestinal disease of any cause. Because as I alluded to earlier, and this is a very good example, even though you seem to be managing the underlying disease effectively, some animals just don't respond unless you normalize their serum cobalamin. So make sure you measure it. So what about the outcome? Within a few days of starting Cobalaplex, Bella's fecal consistency normalized. About a month later, she returned to a normal body weight. The owners were very happy. And we rechecked cobalamin 4 weeks later, and it was above the reference range, which is not a bad thing. That's a good thing, if anything. So don't be worried about an above reference interval cobalamin when an animal's being supplemented. Shows the oral Cobalaplex is working well. Okay, another question for you. So how do you currently supplement cobalamin in your patients? Do you give it orally? Do you give it parentally? Yet you don't supplement cobalamin, or maybe there's other ways. And I definitely used to always use injectable cobalamin when I was in practice, and until relatively recently we've always used injectable cobalamin. We would now use Cobalaplex as an oral preparation. So yeah, parental has been really the recommended route of administration in dogs and in cats with cobalamin deficiency for a long period of time. But we know in human patients that there's a number of adverse effects: pain on injection, local tissue reaction, more severe tissue reaction, and I'm sure that animals get these side effects as well. I know they definitely get pain on injection. I didn't used to enjoy giving it via the injectable route. And so for a long period of time, oral cobalamin is prescribed to human patients with cobalamin deficiency. And there's many studies from decades ago to show that oral cobalamin is effective as parental administration in restoring serum cobalamin in humans. And in fact, by hyper-supplementing, it's been shown to aid absorption by mechanisms that are independent of intrinsic factor. So yeah, why not supplement cobalamin orally to cats and dogs? And so there is evidence in the peer-reviewed literature. There's a study from the Journal of Veterinary Internal Medicine here from a few years ago now to show that oral cobalamin supplementation, this was in 51 dogs with chronic enteropathy, and this was just looking at oral supplementation. And as you can imagine, serum cobalamin concentrations increased significantly, and dogs returned to normal serum cobalamin levels in these 51 dogs with chronic enteropathy after a variable period of time after supplementation. And so the conclusion was that daily oral cobalamin supplementation is cheaper, simpler, and pain-free alternative to weekly injections. And there's other studies in other diseases as well, and studies as well in cancer. So hopefully you're aware of Cobalaplex. So this is obviously an oral cobalamin supplement available for dogs and cats. Comes in sprinkle capsules, contains cobalamin, but also folate and a prebiotic or a prebiotic mix, 50-50 combination of fructooligosaccharides, which has got a simple structure and is therefore rapidly fermented, and then also acacia, which has got a more complex structure and is fermented more slowly. And this combination provides a prebiotic effect along a greater length of the intestinal tract. So you'll remember that prebiotics are compounds that induce the growth or activity of beneficial microorganisms, especially bacteria. And when we briefly talked about the pathogenesis of IBD, we said that the imbalance of the microbiome was one reason why animals may develop IBD. So you can see the reasons why prebiotic has been included in Cobalaplex. So again, this combination of a rapid and slowly fermenting substance. And also, Cobalaplex contains folic acid or folate, which is another water-soluble B vitamin, essential for DNA synthesis and repair, and therefore plays a key role in cell division and growth. And folate and cobalamin have got a synergistic relationship and are coenzymes in several important metabolic processes. And there's an example of one of those on the right-hand side, the pathway that converts the amino acid methionine to cysteine, which is a necessary step in the formation of glutathione, which is an essential antioxidant. So yeah, we know that low cobalamin can result in severe metabolic consequences, and is associated with a negative outcome. And in fact, we would tend to start supplementing cobalamin when the serum levels are in the lower end of the reference interval, rather than only supplement when serum cobalamin is below the reference interval. Once you start to get into the lower end of the reference interval, I would also supplement it, because serum cobalamin is probably quite a poor marker of cobalamin at the cellular level. You can also do other things to assess, probably more accurately assess cobalamin levels. And so you can assess serum methylmalonic acid concentrations, and you'll actually find out that by assessing that, a significant percentage, 19% of dogs with cobalamin within the reference interval, at the lower end of the reference interval, but still within the reference interval, appear to be deficient at the cellular level. So measuring MMA is a better indicator of cellular concentrations of cobalamin. So take-home messages: supplement these animals when the cobalamin is at the lower end of the reference interval. And the package insert has a number of capsules depending on the body weight, and of course you can increase and decrease the amount you're giving these animals to maintain normal serum cobalamin. I would normally supplement for 4 or 6 weeks, remeasure cobalamin, after 4 or 6 weeks. It doesn't really matter which of those you choose. If you're managing the underlying disease correctly, once you've restored normal levels of serum cobalamin, you shouldn't then need to continue supplementing it for the rest of the animal's life. Obviously, if there's a relapse at any period of time in clinical signs, it makes good sense to measure serum cobalamin at a point in the future. But generally, once you've restored serum cobalamin back to normal levels, as I say, you shouldn't need to necessarily supplement it long term. So this is a brief summary of what we've talked about. We have said that cobalamin binds to intrinsic factor and is absorbed in the ileum. Its main function is as a coenzyme, and it's important in many physiological processes. Deficiency is common in animals with chronic enteropathy and also exocrine pancreatic insufficiency. And the deficiency causes a number of clinical consequences, which include things like anorexia and neuropathies, immunodeficiency, villus atrophy, and malabsorption. And then traditionally, supplementation has been parenterally, but there's data to show that oral cobalamin is effective as parenteral administration in humans, and there's also data to show that by giving high doses of oral cobalamin, that can also normalize serum cobalamin, and that's from clinical experience as well. And yet, there's an oral cobalamin supplement which contains folate and a prebiotic. So I hope you found that useful. There's my email address if you've got any questions, and thank you for listening.
Thanks, Nick, for providing such an engaging webinar. And now we're just going to have a few words from Protexin Veterinary, who have sponsored this webinar. Firstly, a brief introduction to myself. My name is James Henderson, and I look after the export of our veterinary range around the world. And today, I just wanted to give you some very quick information about Protexin and the international availability of our products. As the UK's largest manufacturer of veterinary probiotics and supplements, we're focused on producing innovative, research-based products that are of really high quality. And every product we produce is manufactured in our own state-of-the-art facility in Somerset, as you can see in the image here. And this allows us to be completely in control of our commitment to the highest quality standards. Everything that we manufacture is extensively researched for safety and efficacy, and we work closely with leading universities and research centres around the world on a range of ongoing research programs. So you can be confident that when you use a Protexin product, you are getting the highest quality, natural products backed by effective science. During Nick's webinar, he mentioned Cobalaplex, and this is one of several products that we manufacture that contain cobalamin. We also make a product called Procolin Enterogenic, which contains multiple other ingredients targeted at chronic enteropathies, in particular IBD and intestinal dysbiosis, and Proenzorb, which is specifically designed for use in exocrine pancreatic insufficiency. You can find out more about these products at our website, www.protexinvet.com. And just a note, if you're watching this from Australia or India, then you may have seen this product on the market as Cobalazorb. And just to let you know that Cobalazorb is exactly the same as Cobalaplex and will have all the same clinical indications and benefits. Our products are available in over 50 countries worldwide. To find out more about availability in your region, please visit www.protexinvet.com/worldwide-distributors. Alternatively, you can reach us by email at vetexport@protexin.com for more information.